So we're going to start Module 6 now. This one should be a fairly fairly quick one. We're going to go over the individual drug classes, not necessarily when exactly to use them in therapy, because your notes are pretty complete in that aspect, and a lot of these are used for multiple GI illnesses. So we're going to kind of just go over the high points of each class. So just as an overview, these are the categories we're going to go over during this module. So antacids are your basic treatment of heartburn. Again, heartburn is not the same thing as GERD. Heartburn is happens occasionally, is brought on by can be brought on by certain foods. Certain people may get heartburn after they eat greasy foods or carbonated beverages or things like that, where the stomach is producing an excessive amount of acid, and we give an antacid to balance out that acid. All it is a metallic cation and a basic ion. So you're going to see that the most common combinations are aluminum, calcium, and magnesium. So this is over-the-counter Tums and things like that can be taken within 30 minutes of eating or shortly after. They work for a couple hours, and then their effect fades off, and there's no long-lasting effects from it. You'll also have some combinations that have a differing acid neutralizing capacities. Some have sodium bicarb or calcium carbonate, and those have the highest acid neutralizing capacity in antacids. So a little bit of pharmacokinetics to keep in mind. Aluminum and magnesium-based antacids are not absorbed with normal use, but chronic use will increase absorption, and they are renally at that point they're renally excreted. Calcium-containing antacids require vitamin D for absorption, so that's if you're taking it as an antacid and as a calcium product for someone who say has osteoporosis, then you would need the vitamin D in conjunction. So precautions, for the most part, they are fairly benign. You obviously, if a patient has high calcium or has kidney stones that are calcium based, then you would want to avoid calcium based antacids. Magnesium and aluminum antacids you want to avoid in patients who have severe renal dysfunction. And every once in a while, you want to watch the sodium content. Unless your patient is just chewing these continuously, it's not going to provide enough to really take effect or to have an effect. Adverse drug reactions, magnesium-based ones cause diarrhea. The other two cause constipation. That's pretty much it. Drug interactions. The drug interactions with antacids are all based on does the other drug require an acidic environment to be absorbed? If it does, obviously with giving antacids, we're making that environment more basic and increasing the pH, so we're not going to have an acidic environment. So you'd want to separate those antacids by a couple hours. The other interaction you're going to have is with medications like fluoroquinolones. They actually chelate, so with the fluoroquinolones bind to the antacid and make it non-absorbable. So you have to separate those out by 2 hours also, so that one can be absorbed and then the other one is given. So even if you need to, give one if they're taking antacids at meal times, maybe give the fluoroquinolone antibiotic at bedtime. So there's enough time in between each one so that it can be properly absorbed. Antacids, they are used for symptomatic relief of heartburn. Again, it doesn't say GERD, long-term GERD treatment. I do think those are a little confused every once in a while, GERD and symptomatic heartburn. But again, this is kind of that PRN symptomatic relief, or for very, very short term, up to 4 times a day dosing. While they're getting other medications on board, or until lifestyle changes have been made. You also use them in peptic ulcer disease as an adjunct to other medications. You do use them in GERD. They're going to be they're going to either be PRN or just when they have symptoms. But you always want to use an H2 antagonist when they're on the market. When we get to those, we'll talk about what's going on right now with Zantac and all the other ones, or a PPI as mainstay treatment. And again, all these treatments for most of these are intended to be short-term therapy. Um, we're not, unless you have a history of ulcers or other Barrett's esophagus or other long-term GI disorders, none of these are intended to be long-term treatment because the stomach needs acid, and the longer you keep someone on it, even these antacids, they're going to have rebound um, hypersecretion, so it's going to be very, very hard to get them off of it. Again, it's easy to for which one to pick. Basically, cost is the first thing to consider, and then also how the renal function is. Some things to educate your patients on. Lifestyle changes. This is, really should be higher up in the slides. Lifestyle changes should always be your go-to for any disease state that it's applicable to. So any of these things would be a long-term effect for patients as opposed to the short-term treatment of medication. So suggest all these to your patients who have heartburn. Antidiarrheals. So you're going to have a couple of these, absorbent preparations. You can have those. Bismuth subsalicylate is Pepto-Bismol. Opiates are used quite often. Imodium is over the counter. Taken in. It's over the counter, even though it is an opiate derivative, because it's very safe, and the amount that you would have to take to get some kind of euphoric effect is you probably can't find enough on the shelf to to take it. So, but Lomotil, another one, is a prescription-only controlled substance. So I usually suggest going with Imodium first and then Lomotil secondary, or using keeping Lomotil for patients who maybe are in an inpatient setting. Metofen, I've never actually seen that one used. It's not common. Most pharmacies are not going to carry it. And Imodium and Lomotil are definitely the way to go as far as antidiarrheals. Some of these other ones are more so are for other certain disease states. We're not going to go into them because you're not going to use them quite as often. But you can see here that their specific pharmacokinetics, kaolin and pectin, are not absorbed and are eliminated in feces. Bismuth subsalicylate dissociates into salicylate that is absorbed. You can go through, and again, keep in mind that's a salicylate, so that is in the same category as aspirin and some of your other NSAIDs. So you can't use it. You're not supposed to use Pepto-Bismol or bismuth subsalicylate in patients who are at least under 13 years old, preferably until they're adults. You would like to wait until they're adults to use that because of the risk of Reye's syndrome. Adverse drug reactions, obviously, number one would be constipation. If you're, because you're trying to, that's what you're going for. The bismuth can cause a black tongue and a gray-black stool. Make sure that you warn your patients about that, because some people know that a black tarry stool is a sign of a stomach bleed. So they may be worried when they have that change in stool, and let them know that it's the bismuth. That it's not the Pepto-Bismol. It's not something worse. The diphenoxylate or the Lomotil and atropine will have anticholinergic effects. Remember, we talked about that last time, that it can cause dry eyes, dry mouth, urinary retention, and constipation. And then your opioids can have effects on the CNS, and you probably are only going to see that if you're using Lomotil scheduled, 3 or 4 times a day. So if you have acute diarrhea, you're going to treat the source of the diarrhea, and then you're going to use these main options To treat, again, maintain hydration, and then opioids, the Imodium or the Lomotil, 3 to 4 times a day after each stool. And with like Imodium, you're going to give, it's a 2 milligram tablet. You want to give 2 tablets with the first loose stool, and then 1 tablet with every subsequent one for a maximum of total of 8 tablets a day. Again, you can see here where the specific use when it's irritable bowel syndrome, bowel disease, traveler's diarrhea, things like that. Again, you want to educate your patients on the black tongue and stool with the bismuth, anticholinergic effects, and then get into the specific medications if you're treating IBS or something like that. Cytoprotective agents, you've got NSAIDs that for people sometimes who are on NSAIDs, they cause gastric mucosal damage and ulcer formation. So you can have cytoprotective agents. So that should be sucralfate. It starts with an S, or Carafate. That's the one you're going to use 99 times out of 100. It selectively binds to the ulcer and acts as a barrier. Now, something that's I think is a common source of confusion. Sucralfate or Carafate does nothing to the pH of the stomach. It just protects the ulcer from stomach acid so it can heal. That's all it does. We see a lot of patients who get a PPI and Carafate for GERD, and all you're doing is adding pill burden, because that sucralfate is taken at least it's taken 4 times a day, and that becomes very, very burdensome for a patient. The other one, misoprostol or Cytotec, inhibits gastric secretion and has mucosal protective qualities. This one is not used very often for that reason. It's also used in abortive procedures. A wide array of those, whether it's for a blighted ovum or miscarriage or whatever it may be. But because of that risk of reproductive, that reproductive risk, it's not commonly used for the cytoprotective agents unless there's no other option. So again, misoprostol is a pregnancy category X. It is a known abortifacient, so you want to avoid that in women who are in reproductive or childbearing years. ADRs, sucralfate can cause constipation. Misoprostol can cause diarrhea and menstrual problems. And drug interactions, basically, it can decrease absorption of other drugs. So these are the top use in ulcers that are associated with NSAID use. The first choice is obviously to stop the NSAIDs. You dose them 4 times a day, and women of childbearing age need a pregnancy test for misoprostol, but probably just better off using sucralfate if you have to. If you have an ulcer, you give sucralfate for up to 8 weeks to let the ulcer heal, and then you can discontinue it once that ulcer is healed. Antiemetics, so for relief of nausea and vomiting, and prevention of fluid and electrolyte disturbances. So you're going to have antihistamines, phenothiazines, which are also known as antipsychotics, and sedative hypnotics and anticholinergics. Cannabinoids, 5-HT3 receptor antagonists, or your triptans, and then the new ones are the NK1 receptor antagonists. Let's see. We're not going to talk about antihistamines. We've gone over those enough. Phenothiazines block dopamine receptors in the chemoreceptor trigger zone, so they work in to decrease nausea and vomiting. Cannabinoids, not surprising, they prevent nausea and vomiting associated with cancer and chemotherapy. That's where they're used. You'll see like the dronabinols used there, Marinol, brand name Marinol, used there. Your triptans block serotonin in the vagal nerve terminals. Anticholinergics are like scopolamine, so for motion sickness. So precautions and contraindications. Ones to note: phenothiazines, they can produce extrapyramidal side effects most of the time in the doses that we're using. It's very, very rare. These, you're talking about medications that need to be several hundreds of milligrams, 600-800 milligrams a day for antipsychotic effect, and we're using 25 to 50 milligrams. So there's a very low risk, but it can happen. And so you just have the patient stop taking it. They go away. We're not really at a risk of tardive dyskinesia, which can be long term because we're not going to use it long enough for that. And it's definitely contraindicated in Parkinson's disease because those patients already have low dopamine, and we don't want to make their symptoms any worse. Dronabinol, using caution with patients with seizure disorders. There are other medications, and triptans, they may mask a progressive ileus, so it's something to watch out for. ADRs, pretty straightforward, nothing surprising. The 5-HT3 receptor antagonist, this is what you're going to give, Imitrex, all the triptans, which have varying lengths of activity, onsets of activity and durations. Mostly you're going to see possibly constipation and fatigue and dizziness, but they're also throwing up. So how which one causes which? I think they're relatively benign, so there's not a whole lot of adverse drug reactions. Drug interactions, you can see here, there's not that many of them. It's mostly additive effects. Clinical use for nausea and vomiting by drugs or gastroenteresis. Your triptans, 5-HT3 receptors are first. Phenothiazines, not in children. And then dronabinol is only used for chemotherapy-associated nausea and vomiting and for appetite stimulation. And we have some patients who we're using that for, whether they're on chemo or they're elderly and dementia is causing disturbances in their independent living, in their daily living skills and eating, and so we're stimulating their appetite so that they get enough nutrition. Motion sickness, you're going to use antihistamines, and then you can give prokinetics for vomiting caused by gastroparesis. Monitoring, if it's short-term use, there's no monitoring to do. Long-term use of promethazine requires a CBC at week 4 and week 10, but that's not commonly used long-term. Patient education, very straightforward. Lifestyle changes. So that's about it for antiemetics. H2 antagonists, we're going to talk about these. Right now, these are not on the market. What happened is Zantac was found to be the formulations contained a carcinogen, and so the FDA pulled all of Zantac from the market, the ranitidine. And so what happened was when they pulled that from the market, it had the highest supply of any H2 antagonist, so we quickly used up what we had of the other H2 antagonists. So at this point, there's nothing left, and at some point they will come back to the market, but it's been about a year, at least a year. I would say that we haven't had an H2 antagonist on the market to use until they fix the formulation and get recertified by the FDA. But what an H2 antagonist does is it reversibly blocks the H2 receptors, highly selective, and reduces gastric secretion by 35 to 50%. Now these are all, as far as the class goes, they're all equally effective. When they're all on the market, I prefer ranitidine first because it has low drug interactions and it's less times a day. Then you can go to famotidine, and then the one I try to avoid is cimetidine because of all the drug interactions it has. You want to use it cautiously in renal impairment. Hepatocellular injury can occur with nizatidine. I don't use that one a whole lot just because of the price. It's the newest one to the market, so I don't use that one when Zantac is a couple dollars over the counter. They are pregnancy category B, which is good, so it is an option for your pregnant patients, and ranitidine and famotidine are approved for use in children. Adverse drug reactions. Cimetidine is really the only one I have seen personally with the gynecomastia and impotence, the anti-androgenic reactions. Your CNS CNS adverse reactions. I haven't seen a whole lot of that. That's very rare. And the agranulocytosis and those listed below are very rare also. Drug interactions, a lot of drug interactions with cimetidine, not a whole lot with the other ones. So I just tend to avoid it because a lot of medications go through cytochrome P450 1A2 and 2D6. And monitoring, you monitor liver function with high dose or long-term use, so over several years. Here's your clinical usage. It tells you when to use them, when not to. Patient education, administer it. You take it with meals and separate antacids by 30 minutes to an hour. Most of these you can take twice a day. Take it with breakfast, take it with dinner, and that'll cover lunch and bedtime also if they have heartburn then. So think about it as antacids 4 times a day, H2 antagonists 2 times a day, and PPIs that we'll get to 1 time a day. Here's a chart of equivalent doses that we use at the hospital to switch everybody to Zantac when it's on the market. Real quickly, prokinetics, they stimulate the motility in the GI tract. Metoclopramide is the only drug in this class, and it has some action similar to phenothiazines and dopamine antagonists. So keep that in mind for patients who have Parkinson's or who already have extrapyramidal side effects due to antipsychotic medications. Precautions, again, it can cause tardive dyskinesia because of those dopaminergic blockade. They are contraindicated in GI hemorrhage, mechanical obstruction, or new surgery on the GI tract, and used cautiously in patients with a history of depression. ADRs, seen a little bit of these. The ones I have not seen are hypoglycemia in diabetic patients, and then obviously those rare ones at the bottom. Here's clinical uses of them, pretty straightforward. Monitoring, patient education, take 30 minutes before a meal, do not double up on doses, and can cause some drowsiness. PPIs, we're seeing a massive boom in PPI use in the past few years. Part of that is because they're now available over the counter. Just their availability. There is a reason why those boxes over the counter are made in 14-day packs, because they should only be used for 14 days without consulting a healthcare provider. And most people take them, honestly, for too long without any true indication for them. But we'll get into that. So they're used for hyperacidity for erosive gastritis, GERD, Zollinger-Ellison syndrome, and a part of the treatment of peptic ulcer disease. Administration of traditional PPIs 30 to 60 minutes before the meal, because it has to be available to block the proton pump when it produces acid based on response to food. So if you give it and somebody doesn't eat for several hours, it's not going to do anything. They have to eat afterwards of taking it. So I like to tell them to take it about an hour before their largest meal of the day if they can. That way they take it, they eat, the stomach starts to produce more acid to digest the food, and then the PPI can come in and block that pump so that it just can't keep pumping. And it's a long-term blockade, so with every subsequent day, this is not a PRN medication. It takes several subsequent days of blockade of the pumps to decrease the overall pH. So decrease in acid secretion lasts up to 72 hours after each dose, and they build after each dose. So you would use this for several days, not for PRN usage. Pregnancy category B or C, depending on the medication, and precautions in extensively metabolized. It's extensively metabolized in the liver, so watch out for patients who have hepatic dysfunction. ADRs, these are coming to light a little bit more for long-term use. So risk of significant nutrient deficiencies like iron, B12, and calcium. That's because a lot of these like an acidic environment to be absorbed. When you're making it more, increasing or decreasing the acidity in the environment, they're not going to be absorbed as well. Long-term PPI use may cause an increased risk in osteoporosis and hip fractures. It can cause an increased risk of opportunistic GI infections. increased risk of pneumonia, GI cancer risk, kidney injury, chronic kidney disease. I've seen some links possibly to dementia. They're not. I'm not sure if they're as benign as we thought they were. 5 to 10 years ago when we started putting all of them on the market and making them accessible, so accessible without a prescription, because I think people tend to get on them and then never get off of them, and it's hard once they've been on it for several months. So rebound hypersecretion is you know when therapy is discontinued in individuals, uh, or can happen for patients who have received therapy for 2 weeks or more. It is going to happen there that if somebody's been on this medication long term, they need to be tapered off of it. So go from half the dose, then go to every other day dosing, every third day dosing, and slowly back off, because the stomach, if you stop it immediately, once those receptors are blocked, it's going to dump in a lot of acid. It just is, because the stomach has been used to having that blockade and trying to overcome it, through negative feedback. There's been an increase in the receptors. Sorry, there's been an increase in receptors, an upregulation of those transporters. So it's trying to produce more acid to overcome the medication, and then once you stop it, just kind of overwhelms the stomach. B12 deficiency can occur long term, and hypomagnesemia. So you want to check that in patients. Drug interactions, straightforward, mainly Plavix with omeprazole, and then watch for patients who are on antiretroviral therapy for HIV infections. They're used for ulcers, to treat H. pylori, and then also for GERD, used for 8 weeks, and then the patient is weaned off. Important thing is to try to wean the patients off slowly. More patient information, equivalent doses of PPIs for you to use in the future. Here you go, decreasing twice a day to once a day to every other day, slowly titrating them off so they don't have that rebound secretion, because once they have it, they're going to ask to stay on the PPI forever. You're not going to be able to get them off of it, and then we could be causing issues in the future. Laxatives quickly. These are the classes. Most of them are available over the counter, except for this lubiprostone and methyl naltrexone. Those are prescription only, for used in certain instances. How they're used: surfactants are commonly used, hyperosmolar laxatives. Again, these are commonly used, just for over-the-counter usage. We're not going to talk about them too much. ADR is not surprising. We're trying to get the GI tract moving, so cramping, flatulence, and bloating. Prevention is key for lifestyle management. Laxatives are only temporary fixes. That's something to keep in mind. Here's a chart of medications that may cause constipation. So obviously we want to stop a medication before we start something else. And here's a chart of commonly used, or the most commonly used medications for constipation, when to use them, the dose, the route, common adverse effects, and any additional comments if necessary. Real quickly, GERD and peptic ulcer disease. We're kind of going to skip GERD because this goes over the same medications but when to use them. We're going to go to peptic ulcer disease, which is is not uncommon in people. You can see 12% in men, 10% in women, lifetime incidence. It is commonly associated with NSAID use, which leads to an H. pylori opportunistic infection. So step 1 is lifestyle modifications and over-the-counter. Step 2, if you have H. pylori testing, then you're going to treat with PPIs and combination therapy. So the treatment for an H. pylori infection is triple therapy. It's a PPI plus clarithromycin or metronidazole and amoxicillin. You treat for 10 to 14 days. There are packs of this medication, of these combinations that come together, but they're really expensive, name brand only. So it's a lot easier if you write them out as 3 separate prescriptions. The patient's probably going to pay $10, $20 for this, where they would pay about $100 because the insurance is not going to pay for the pretty pack, that the Prev pack or whatever the combination it comes in. These are all generic. They're covered by most insurance companies if they're written as separate prescriptions. There's also quadruple therapy if they need to avoid one of the medications mentioned earlier, PPI plus metronidazole and tetracycline, which is actually not it's taken off the market at this point, and bismuth subsalicylate, and you would use it as second-line therapy for people who fail first-line therapy. There's also levofloxacin-based triple therapy as another option, and you may want to consider adding probiotics that include one of these two types of bacteria as adjunctive therapy. So after treating the H. pylori for 10 to 14 days, continue the PPI for 8 to 12 weeks to promote healing. And if they're at low risk, then no further treatment's needed. If they're at very high risk, you may want to do chronic acid suppression. Again, here are the charts that tell you your options, how you can avoid certain antibiotics, amoxicillin if they're allergic, metronidazole if they can't, have certain, to avoid certain drug interactions. And then here are some charts, just 2 pages quickly on Difficid for C. diff infections. In the past few years, this part is not in your book, but in the past few years, this has become first line with oral vancomycin for C. diff infections. So I'm just giving you the little bit of information so you're familiar with it. But overall, that is Module 6, and I will see you for Module 8.